Hello, my name's Dr. Leon Creaney, and I wanted to speak to you today about the management of early osteoarthritis in the hip and knee. This talk is not about the late management of osteoarthritis, where clearly knee replacement and hip replacement are required. This is for the earlier stages of the disease. My name is Dr. Leon Creaney. I'm a consultant in sport and exercise medicine in private practice, predominantly around Manchester and Cheshire, and all of these knee treatments are still available. There are structural abnormalities in both joints that can be identified as risk factors for the development of hip osteoarthritis. They can be seen from childhood onwards, shallow sockets such as hip dysplasia, and problems that are seen in childhood, for example, slipped upper femoral epiphysis and Perthes disease, will lead to osteoarthritis in later life. There are certain genetic factors that will predispose to osteoarthritis in the hip, for example. It is known that there is a familial tendency and abnormalities in specific chromosomes. A shallow socket known as acetabular dysplasia increases the loading of the articular cartilage on the surfaces that are articulating, and this does cause premature failure of the cartilage, as does pincer morphology and camber morphology, which predispose to femoroacetabular impingement and labral tears. And I've also mentioned these two other conditions, slipped capital femoral epiphysis and Perthes disease, which are childhood conditions. In the knee, we have a similar set of factors. Being overweight and obese is a very significant risk factor for the development of any lower limb arthritis, but in the knee it is known that previous injury is a very big risk factor. Torn menisci, injuries obtained traumatically to the articular cartilage, and instability in the knee, for example with an anterior cruciate ligament rupture or posterior cruciate ligament rupture, significantly increase the chances of developing arthritis in later life. People do ask the question, does running injure the joints? In healthy, non-overweight people, running does not appear to cause any articular cartilage damage at all. However, running when you are overweight or if you have a previous injury in the joint is known to accelerate the deterioration. So running is generally healthy for joints unless you have a previous injury or you're overweight, and in that case I would not recommend running as a sport. I would suggest that swimming and cycling are better alternatives. Coming back to the hip here, we mentioned this previously, different shapes of the hip bone can predispose to premature osteoarthritis. This is cam impingement, where you have an extra bump of bone where it articulates with the socket, and the pincer deformity, where there is over coverage of the bone, causing pinching of the articular cartilage when the hip is flexed. And this is what those abnormalities look like on a CT reconstruction. So just summarising in the hip what some of those abnormalities are and the radiological criteria that need to be met to diagnose those abnormalities. Looking at some x-rays here, we can see these typical deformities. Picture on the left is of an extra bump of bone, so-called cam deformity. The picture on the right, you can see the socket is very shallow. The hip doesn't go very deeply into it, so the part of the joint that is articulating has to take more weight and the joint fails early. The picture on the left, the joint looks fairly normal, but the picture on the right, you can see a significant joint space loss. And this is a pincer deformity on the left hand side and a more severe pincer deformity on the right. And this is a picture of childhood Perthes disease, many years down the line after childhood. Avascular necrosis of the femoral head has led to collapse and deformity and premature osteoarthritis. Now, late osteoarthritis in the hip and the knee is very easy to diagnose. It's already visible on X-ray. However, people do develop symptoms around the hip and knee many years before X-ray changes can be seen. This paper was published in the British Medical Journal a few years ago, demonstrating that people with clear hip osteoarthritis and pain can have normal X-rays. And it's concluded that hip X-ray has both low sensitivity and specificity for the diagnosis of hip osteoarthritis in people with hip pain. We get similar findings in the knee. This is what a late knee osteoarthritis X-ray looks like. The cardinal signs of osteoarthritis on X-rays are loss of joint space, hardening of the bone, so the bone is seen as being more white, which is called subchondral sclerosis, new bone formation known as osteophytes, usually at the edge of joints, and you do start to see cysts forming in the bone. There is a scale of severity used, which is called the Kellgren-Lawrence scale, with grades 3 and 4 being the more severe. We tend to operate non-surgically around grades 2 and 3. So really, the diagnosis of early osteoarthritis in joints is more dependent on MRI. It is far more sensitive and will lead to a diagnosis many years ahead of an X-ray. We can see some typical changes of osteoarthritis in the knee here on a knee MRI. This knee has a bone marrow bruise or lesion. We can see early thinning of the cartilage on the femur there. There is also fluid in the suprapatellar pouch. You can see some dark debris there, which is synovitis. The cartilage at the back of the kneecap is very thinned. We can see a single osteophyte on the superior pole and also a subchondral cyst. All of these changes would simply not be visible on a knee X-ray. In hips, we get similar findings. We use different classification systems in the hip. We can see that disease severity and pain does actually correlate quite closely with the amount of bony edema seen and also the amount of subchondral cyst formation. People with worse bone marrow edema tend to have a worse experience of pain. And cartilage lesions within the socket seem to correlate with pain better than cartilage lesions in the femur. Interestingly, no association of pain with labral tears. Sometimes, however, it can still be very difficult to know whether a person's groin pain is genuinely coming from the hip joint or whether it's coming from an extra articular structure. And in these occasions, we need to do what's called a diagnostic injection. So using X-ray control, we place a needle into the hip joint, we infiltrate it with a long-acting local anaesthetic and some steroid, and we see if the pain goes away. Using this methodology, the sensitivity and specificity for hip pain you can see is in the 90s, so we're unlikely to make an error. It's very easy to diagnose hip arthritis in the knee, and it's very rare that a diagnostic injection needs to be performed. I just wanted to speak for one or two slides around exercise and weight in osteoarthritis. Obviously, many people who have osteoarthritis say that they cannot do exercise because it's too painful, and therefore they cannot lose weight, and it compounds the issue. To those people, I would recommend non-weight bearing exercise, again, such as swimming and cycling, rather than walking or even running. What we see here is exactly how being overweight affects joints. For every 1% weight gain, there is a change in the angle of the hip. The hip actually starts to remodel and collapse, and increased pressure is placed on the hip joint with increasing weight. This increases the load on the cartilage and causes premature failure, and is a direct link between being overweight and causing premature joint failure. I spoke about running before and just wanted to go over it again. This was a large study done on 75,000 runners, looking at the risk of developing osteoarthritis or needing a hip replacement. And we can see here that the more running a person does, in fact, the lower the risk of needing a hip replacement. However, we look at the bar chart on the right, we can see with increasing body mass index above 22.5, the risk starts to go up. People who are even in the normal category of weight, 22.5 to 25, still have a higher risk due to their weight than people who are in the more healthy range of 22.5 or less. So staying on the subject of exercise, we're now onto the management of osteoarthritis. This would be a typical exercise program recommended to somebody with early knee osteoarthritis. You can see it recommends aerobic exercise and strengthening of the hip and knee with squats, leg press exercises, so on and so forth. All people with early osteoarthritis should work with a physiotherapist on improving their fitness, strength and conditioning level, though in terms of pain relief, it only has quite a small effect. If we want good pain relief in the knee, there are different injectables that we can employ, the most common and well known being steroids. Obviously, steroids are well established, but they do carry a small risk, local reactions, so on and so forth. And I tend to give people these information leaflets prior to doing a steroid injection with the risks quantified. During coronavirus times, there is also a theoretical risk of coronavirus infection, though there is no actual hard data to support this. It remains a theoretical risk only. This was a study done looking at steroid injections in the hip. They compared two different doses. You can see there 40 milligrams versus 80 milligrams of depomedrone. At 6 weeks, both groups had improvement in pain. However, at 12 weeks, only the 80 milligram group continued to have benefit. So we know that steroids can give powerful but really quite short-term pain relief, probably at best 3 months in most people, but it can be a useful adjunct for people in severe pain. Because of the potential joint damage with steroids and the short duration of action, we have over the years looked for alternatives, and viscosupplementation in the form of hyaluronic acid is a very palatable alternative. There are many of these products on the market now, the big three probably being Ostenil, Synvisc and Durolane. I tend to use Ostenil Plus in my practice, and this is the only visco supplement that is regularly authorised by UK insurers. The other two are available, but they tend to be self-paying treatments because they're not covered by insurance policies. So this is a simple injectable that is completely inert. It's not classified as a drug and can actually be bought online by the patient without a prescription, although it does need a practitioner of medicine to inject it. There isn't great evidence for osteoarthritis in the hip with visco supplements. We can see just 1 or 2 studies here, and it is mainly a substance that is licensed in the knees. And there is a nice Cochrane review demonstrating very good efficacy, which is comparable and of longer duration of action in the knees with visco supplements. Some people do ask, well, why can't we inject both? We get a quick action from the steroid, and we get the prolonged action from hyaluronic acid visco supplements, and indeed you can. This is one such trial where they did exactly that, and you can see when you compare a corticosteroid injection combined with hyaluronic acid, you get the early response, which is then maintained because of the HA, whereas with HA alone, you have to wait for the delayed response. The 2 drugs can simply be mixed together, or there are commercially prepared preparations where they come pre-mixed, for example, Singal. And again, there is good data that you get the early response from the steroid injection combined with the late prolonged response from the hyaluronic acid. Moving on to biological therapies, many people have now heard of platelet-rich plasma. Platelet-rich plasma is a substance made from the patient's own blood. We take a sample, we spin it in the centrifuge, and we separate the red blood cells from the plasma, and there is an enriched layer of platelets called the buffy coat, and it's the platelets that contain the regenerative, healing and analgesic factors. It has been well researched now, and there is a growing body of evidence for platelet-rich plasma injections in the knee. This is one of the early studies done in the United States, where they used a low-yield leukocyte-depleted form of platelet-rich plasma in Kellgren-Lawrence stage 2 to 3 knee osteoarthritis. And we can see how well it outperforms a placebo injection such as saline, even after 1 or 2 weeks, and the effect seems to be sustained over 3, 6 and 12 months. There have now been enough trials using platelet-rich plasma in knee osteoarthritis that systemic reviews have been completed, and we've also been able to complete it against hyaluronic acid, and we can see that the 2 treatments are at least equally efficacious. This is the result of several studies, a meta-analysis comparing the WOMAC scores, which is a combined knee pain and function score in knee osteoarthritis for hyaluronic acid drugs versus platelet-rich plasma, and we can see that the trial evidence appears to favour platelet-rich plasma. Again, further somewhat older studies looking at PRP in hip osteoarthritis. This was an early study that showed some evidence of effect. But the data in hips is never as good as it is in knee osteoarthritis. Finally, when we're looking at non-medical treatments for knee osteoarthritis, bracing can be a useful alternative. There are various unloading knee braces which take the pressure off both the medial and lateral compartments. People can actually walk and run in these braces. They need to be fitted by a specialist physiotherapist, but are very comfortable when worn and can stop the pain of knee osteoarthritis very well. The unloader one tends to be used for medial compartment osteoarthritis, whereas the Unloader 1X tends to be used for lateral compartment osteoarthritis. So in summary, early identification of hip and knee osteoarthritis is important, and symptoms do appear many years before X-ray changes are visible. Weight gain is an important risk factor and needs to be addressed. MRI is really the gold standard in the early diagnosis of osteoarthritis, and sometimes diagnostic injections are required. Steroids are very useful for acute pain. They are very potent painkillers, but they don't last for very long. And we now have very good alternatives, such as viscosupplements and platelet-rich plasma. In the future, disease-modifying osteoarthritis drugs and stem cells may be available, but they are not commercially available at the moment. There are other treatments advocated, such as adipose tissue injections. Again, there is no hard evidence for these. I hope you found that useful. Yours sincerely. Many thanks for listening today. These are my contact details, and I am still available for patient appointments face-to-face via Zoom and Microsoft Teams during the COVID epidemic. Yours, thankfully.